Hello everyone, welcome to Medicine Guruji. Another important topic that we will take today is chest pain. Remember students, chest pain is very important. It is very important clinically और डे टू डे लाइफस्टाइल में चेस्ट पेन जब आप इमरजेंसी में या ओपीडी में अपनी ड्यूटी करेंगे तो चेस्ट पेन के बहुत सारे केसेस आएंगे और चेस्ट पेन का अप्रोच करेक्टली समझना बहुत इंपॉर्टेंट है। फर्स्ट, टू सेव द लाइफ ऑफ द पेशेंट, और सेकेंडली अगर आप इसे प्रॉपरली मैनेज नहीं करते हैं तो इट विल लीड टू वेरी डेंजरस आउटकम्स। सो स्टार्टिंग अवर जर्नी, हम शुरू करते हैं इस बात से। फर्स्ट वी शुड लर्न व्हाट इज चेस्ट पेन। इट इज अ वेरी कॉमन सिम्टम इन ओपीडी और इमरजेंसी। It is a subjective phenomenon and may be described by patient as pain, pressure और discomfort. मरीज पचासों मेल की चीजें बता सकता है। सीने पे दबाव लग रहा है, सीने में दर्द हो रहा है, ऐसा लग रहा है कुछ भारीपन है, या वो कह सकता है कि जैसे लग रहा है कोई एक पत्थर रखा है सीने पे। और ही मे इवन टेल, डॉक्टर साहब मुझे ऐसा लग रहा है कि मेरी मौत आ रही है, आई एम गोइंग टू डाई। Now students first see the differentials of chest pain. The chest pain can be central or there can be peripheral in origin. The central chest pains you can remember by a mnemonic I have made that can be used and helpful in exam. First, the cardiac causes. The cardiac causes can be myocardial ischemia, that is angina, myocardial infarction, myocarditis, pericarditis, and mitral valve prolapse. So you have seen these are four M's that explain the central cardiac causes of chest pain. Now seeing the aortic causes are aortic dissection, pulmonary embolus. There can be anxiety. We should not forget this component, that is anxiety. That is very important, mainly in young individuals and mainly in young female individuals. The esophageal causes are very important. Whenever you will see patients in emergency, there are lots of patients of esophageal causes, esophagitis, and there can be esophageal perforation. There can be malignancy even a cause. Now coming to the differentials of peripheral, that is the lung causes can be there, pneumonia, malignancy, TB. There can be musculoskeletal causes, there can be trauma to the ribs, fracture of the ribs, हड्डी टूट सकती है, कोई रीढ़ की हड्डी पसली में कहीं चोट लगी हो, osteoarthritis, and never forget teeth syndrome, that is costochondritis. Whenever we see such differentials of periphery, we should not forget neurological causes, that is prolapse intervertebral disc, and we should also see and have a look and take a history of herpes zoster. Now we will understand some important clinical presentations of chest diseases. हम ये देखते हैं कि जो इंपॉर्टेंट डिजीजेस हैं चेस्ट की, वो मोटा मोटा प्रेजेंट कैसे करती हैं। सो यू शुड हैव अ बर्ड्स आई कि हमें कौन सी डिजीज समझ में आ रही है एट इनिशियल हिस्ट्री टेकिंग। फर्स्ट इज ischemia, myocardial ischemia. Generally the pain is in the center of the chest. The pain may be radiating to neck, never forget to jaw, upper or lower arms, or in the back. We always make a mistake. अगर जॉ का दर्द है, we send it to dental institute कि जाओ भाई दांत दिखाओ. But never forget that jaw pain can be ischemic in origin, and ischemic means cardiac pain. Pain is generally dull, choking, constricting or heavy. I told you कई तरह से मरीज बता सकता है. भारीपन है, ये तक कह सकता है लग रहा है सीने में कोई पत्थर धरा है. पेन में बी डिस्क्राइब्ड एज स्क्वीजिंग. ही में डिस्क्राइब बाय अ फिस्ट, मुट्ठी से, क्रशिंग और बर्निंग. एंड देयर कैन बी breathlessness due to pulmonary congestion. So remember, myocardial ischemic pain, it is central and it may be radiating to neck, upper or lower arms or in the back and even jaw. Now we see the second pathology, that is myocarditis, pericarditis. The typical pain of myocarditis is felt retrosternally to the left of sternum or in the left or right shoulder. Pain is sharp, it is very sharp and may catch during inspiration, coughing or lying flat. Pain may change with movement or respiratory cycle, that is inspiration or expiration. And patient may describe a history of prodromal viral illness. This is very important. History of viral illness. Now another important cause, aortic dissection. Aortic dissection, there is severe pain, central and radiation to back. Patient describes as severe and tearing, very sudden in onset. It is generally accompanied by autonomic changes. The autonomic changes जो उसके संग आते हैं aortic dissection के संग, sweating, vomiting, nausea. A very important is myocardial infarction. Pain may take several minutes or longer to develop. There are too much of autonomic disturbances like sweating, nausea, vomiting, और patient typically describe करता है impending death like I am going to die, anger, enemy. Very 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 important. Always remember, हमेशा याद रखिए, anxiety as a differential. Anxiety can be ruled out by history, and at a clinical point you can also consider the age. Anxiety is very common in young individuals, very common in females. There is typical breathlessness, throat tightness, perioral tingling sensation, and when you will take a thorough history, there is evidence of emotional upset or depression or anxiety features. Not actually depression, but emotional upset. Always remember, very common in our country, respiratory causes. Respiratory causes present as breathlessness, cough, wheeze. There can be fever or pleurisy, that is a sharp chest pain aggravated by deep breathing or coughing. जो पेशेंट जिनको अस्थमा है, they describe exertional chest tightness that is relieved by rest. Also remember, important is musculoskeletal causes. Musculoskeletal में pain may vary with posture or movement of the upper body, and pain may be associated with bending, stretching or turning. A very large majority of patients visiting cardiology emergency, they complain of gastrointestinal causes like gastroesophageal reflux and peptic ulceration. What happens in this case? The pain radiates to the interscapular region. there is dysphagia. The pain is hard to distinguish from myocardial ischemia. Why? क्योंकि it may be even be precipitated by exercise and it is even relieved by nitrates. So we are always confused. Now look at this slide. The chest pain cardiac and non-cardiac presentation. The cardiac presentation is pressure or tightness, sharp or stabbing. The cardiac is diffuse, poorly localized, non-cardiac is well localized, focal. The cardiac pain is associated with physical exertion or other stress. The non-cardiac may be positional, spontaneous at rest. The cardiac may be relieved with rest, usually within minutes. The non-cardiac is no predictable relation to physical exertion. The cardiac prolonged symptoms may represent an acute coronary syndrome. The non-cardiac may last for seconds to even days at a time. Now we will be doing clinical evaluation. Remember, students, cardiorespiratory examination must be done and it must be done in detail. Taking out 12 lead ECG is very helpful. पैरों को देखिए. Legs to be examined for deep vein thrombosis. Chest pain जिसमें JVP raised है, that is accompanied by a raised JVP, possibility of myocardial ischemia or massive pulmonary embolism must be considered in mind. We are dealing with large pneumothorax. There are absent breath sounds, hyperresonant percussion on the affected side. Other chest signs, there can be bronchial breathing, wheeze, crackles that indicate respiratory tract infection. So X-ray must be done. If we suspect pericarditis, there is pericardial friction rub. If we suspect aortic dissection, there is a history of syncope, neurological deficit occurs. And if there is local tenderness on chest wall, think of musculoskeletal cause. Any diseases that is involving pleura, there is restricted rib movement and pleural rub may be audible. It is very important to do an abdominal examination in patients with history of chest pain to rule out कहीं liver abscess तो नहीं है, acute pancreatitis तो नहीं है. So it is very, very important, never miss abdominal examination. What initial investigations? I am not going to talk about detailed investigations. जो इन्वेस्टिगेशन जैसी हमारी डिफरेंशियल्स आएंगी उसके डिपेंड करेगा. द इनिशियल दैट आर कंपल्सरी आर चेस्ट एक्सरे, ईसीजी, 12 लीड ईसीजी, द मार्कर्स, बायोमार्कर्स, troponin T, I, D dimer. Rest investigations you can go according to need and suspected diagnosis that you found on clinical examination, like CT thorax, echocardiography. Always remember important points that I am going to tell you. Patients with history compatible of myocardial ischemia, go for urgent ECG, 12 lead ECG. ECG changes indicating a ST segment elevation, myocardial infarction, suggest that the patient is likely to be benefited by immediate reperfusion therapy. Call a intensivist specialist, seek his advice. When in doubt, measurement of serum troponin is always helpful. But again remember, हमेशा याद रखिए, a negative result should always prompt a repeat sample 6 to 12 hours after a maximum pain. आप 6 से 12 घंटे बाद एक रिपीट ट्रोपोनिन का सैंपल करा लीजिए आफ्टर अ मैक्सिमम पेन. Now we are going to discuss some clinical cases. These cases will tell you how a patient of chest pain presents himself. A 55-year-old man, heavy smoker, presented with history of chest pain radiating to left arm. Look, the pain is radiating. Characterizing the pain as crushing, see the nature, severe and constant starting 1 hour prior to clinic visit while at work. He also presented with nausea and vomiting. These are autonomic features. He had a history of hypertension and he is taking amlodipine. He had family history of heart attack and diabetes and his father died from stroke. On physical examination, he appears obese, a risk factor, pale, diaphoretic with cool peripheries, hypotensive, and has bradycardia. Now, seeing the second clinical case, 50-year-old lady presents with a 3-day history of shortness of breath. Breath shortness came on suddenly. It was associated with sharp stabbing pain over her right posterior chest. She also gives history of coughing up small specks of bright red blood 1 day ago. She had no fever or sputum production. She was feeling well prior to these symptoms. So, students, you can see a case of chest pain can present to you in a variety of ways. He can present to you as a case of pain, as a case of heaviness, as a case of radiating pain that can be sharp, stabbing. He can also present to you with history of cough, pain anywhere localized in the thoracic area or in the interscapular area, and so and so and so. So we have to be very careful regarding the symptoms. Thank you, students. Thank you very much. Have a golden career ahead. Thank you.